Hey people, how you doing? Welcome to the Sports Therapy Association podcast, episode 148. My name is Matt Phillips, creator of Run Chat Live, and this podcast is being recorded, as always, live on the Sports Therapy Association YouTube channel. Normally on a Tuesday, but today's actually a Wednesday, so I'm looking forward to seeing whether our regular live lounge people make it here today, or whether it's totally thrown in being the day after it's normally for the last 147 weeks. But I can see now that people are coming into the live lounge, so it's worked okay. Penny is here, Soma Sports Massage Therapy. The advantage of joining us live, by the way, is you get to come up on our screen if you leave a comment. So I can bring up your logo, I can bring up your photo, and it's a great way of networking. So if you are listening to the podcast and you do like the idea of joining us live, and obviously being able to ask direct questions to the guests, all you need to do is head along to the Sports Therapy Association YouTube channel. Normally on a Tuesday at 8 o'clock. Tonight's on a Wednesday. But if you follow us on social media, UK_STA, then or Matt at Run Chat Live, then you will see ample advertising to let you know where we are going to be. So hi Penny, hi Glenn, hi Nikki Mansfield. Nikki says, evening peeps, happy Wednesday. Thank you, Nikki. Glad you all managed to make it. And other people are coming through now as well. So this month we are focusing on abdominal and groin pain. We've been working our way around the body probably for the last 5 or 6 months with a few intermittent different focuses, and we've arrived at the abdomen and groin. Last week, because it's the first Tuesday of the month, then we had Ask Us Anything, which is where we have members of the STA team and also Tim Allardyce as well joins us to answer your questions, anything to do with the soft tissue therapy industry. If you missed that episode, again, we normally get to about 6 questions emailed to us. It's all on YouTube. You can watch the video there. We're also joined by Dr. Fiona Higgs, who's the host of the Women's Sports Therapy podcast, and also with us was Gary Benson, founder of the STA. So also available on any podcast player, so you can listen to us then. And all of it, video, is available on 𝐷STA.𝐾𝐫 on the website. It's uploaded there as well. There we go. But like I say, this week, or this month, it's going to be abdominal and groin pain. We're shortly going to be talking to Dr. Sarah Rollins, who has been on the show a couple of times before. I think one of only 2 guests who's ever done a back-to-back, but that is understandable given Dr. Rollins' involvement in endurance sports and things like that. But next week, we're going to continue with abdominal and groin pain. My guest is going to be Dr. Dora Papadopoulou, sport and exercise musculoskeletal consultant and orthopedic surgeon, who's going to be talking about sports-related groin and abdominal issues. The week after, which will be May the 24th on a Wednesday, make sure that's made clear across the normal channels. My guest is going to be Benoy Mathew, who couldn't make it for the hip the last time we did that, but Benoy will be joining us from Function2Fitness, focusing particularly on his speciality of groin pain. And then finally in part 4, which will be recorded on the normal Tuesday at 8 o'clock on May 30th, my guest is going to be Jenny Bowell of Bowell Education. We'll be focusing specifically on diastasis recti, which is known as abdominal separation. So, I mean, it's a great 5 Tuesdays in the month this May. So we've got 4 fantastic speakers lined up for you. And tonight is going to be no exception. As always, if you've got any questions, other people are coming in. Tracy Marsh says hi. Tracy Taylor, hi. Gary Benson, who's founder of the STA, has joined us. So yeah, if you guys have got any questions at all, this is your chance. Do please just shout out. I'll give permission to Sarah, Dr. Sarah Rollins, to, if she sees anything that grabs her eye, just to stop me in my tracks and say, oh, so-and-so's got a good question. So do please, Penny here said possibly Greek, Mr. Yeah, I can actually confirm that you are right. You recognise the name Papadopoulos. I think there was definitely some Greek connection there. So Penny, yeah, you're going to be informed on who's that's going to be next week. Anyway, I have left Dr. Sarah Rollins down in the lobby for long enough. So without further ado, in this part 1 of abdominal and groin pain, let's bring up my guest, Dr. Sarah Rollins. Dr. Rollins, how are you?
Yeah, good, thank you. Yeah, Sarah, please.
Oh, thank you very much. That's very nice of you. You can see me, can you? We're doing this, again, you're unique in so many ways, Sarah. And you're the only guest I know who you're watching on YouTube and joining me via the Live TV software. So, but you're managing to see me and hear me at the same time, are you?
I am, yes, yeah.
Fantastic. And there's not too much of a lag?
Don't know yet.
Oh, okay.
We'll find out.
Once it starts back in the year. Okay, wonderful. So good to see you. Like I say, you've been on the show a couple of times before, back to back. One of them was you were here in January. That flew by in episode 133, talking about the anatomy behind buttock pain. And as we were saying off air, I mean, we get regular feedback, and I thank everybody who emails in. Never feel embarrassed about emailing in. It's just a few words. Really great, and it helps us form the future of Sports Therapy Association podcast. But yeah, everybody loved the way you described the anatomy behind buttock pain and the visuals you gave with your models and things. So I'm really pleased that you were able to come back and this time do your magic with abdominal and groin pain. So thank you very much. And then you came back the week after with past colleague, sound of bells in the distance, 𝐸𝐫𝐸, who has gone off to other pastures to discuss, wonderful case history that you had. So yeah, if you're interested in buttock pain, I would definitely recommend, guys, that you check out 133 and 134 on your favorite podcast app. So how are you, first of all?
Yeah, good, thanks. Yeah, busy as always.
Of course you are. For people who haven't actually listened to the other two episodes, could you just give us a little breakdown of your history and what you do?
Yeah, so I'm a consultant in sports and exercise medicine. I am an ex-army doctor and left the army in 2009. I've been working in sports medicine for quite some time now, but I started working in the MOD rehab centre in Aldershot in 2012. I've been doing that job ever since, and in October last year, I started working part-time for Pure Sports Medicine in Rains Park. So I now do half for the MOD and half for Pure Sports Medicine, which just is a nice change because I'm now exposed to a wider selection of the population. So not just people between the ages of about 18 and 50 now get to see children down to about age 8, and obviously anybody above that. So yeah, it's just a new facet to my work, which I'm really enjoying.
And you've got a particular interest
Yes.
in musculoskeletal ultrasound, which I think we might be touching on tonight in relation to abdomen and groin pain.
Yes, that's right. So I've got two main interests. I am a teacher or mentor for musculoskeletal ultrasound, and that's what I did my master's in. And in particular, I'm also very interested in women's health rehab, and in particular the anterior abdominal wall, and in particular ultrasound of the anterior abdominal wall. So it's kind of why I'm back here, is because it's kind of like my little niche topic, and so I thought I'd come and talk to you about the thing that I enjoy most of all. Yeah, hopefully you'll enjoy it.
Thank you very much. Fantastic. Well, look, I think we can delve right into it. So last time, I mean, you've got big shoes to fill, but they're your own shoes. Everybody's amazed by the way that you described the anatomy of the buttock. So yeah, anatomy of the anterior abdominal wall. Over to you.
Right. Well, okay. So where to start?
No pressure.
Yeah, no problem. So I'm going to try and break it down so that it's actually mostly simple and is a very logical way to break it down. So we can break it down into its layers and we can break it down into its components. So if you think about the region we're talking about is basically from the edge of the rib cage down to the top of the pelvis. So you can imagine that it's kind of this shaped at the top with the two rib cage like that, and then you've obviously got the side of the body, and then it's this shape at the bottom down from the pelvis down to the pubic symphysis. So you have a I don't know what that shape is, up the sides like that shape, and that's the anterior abdominal wall with the umbilicus in the middle. So we've obviously got our anterior layer, which is our skin. Then we have a layer of adipose tissue, so our fatty layer, and some loose connective tissue. And then the next layer is the aponeurosis of the external oblique. So that is a kind of thick tendinous structure that sits as the front of the anterior abdominal wall and is part of external oblique. So we have three layers of muscle at the anterior abdominal wall. on the kind of sides of the abdomen. And then in the middle, we have two rectus muscles. So they're strap-like muscles in the middle, which is your six-pack. And on the side, we have external oblique. So at med school, and I still remember it now, external oblique muscle is like putting your hands in your pockets. So if you think about where the striations go, it contracts like that, because if you put your hands in your pockets, that's the way the striations go. Internal oblique goes up like this. It's just the opposite. That's the next layer in. And then we've got an inner layer of muscle, which is transversus abdominis, which is like putting your hands into the front of a hoodie, for example. And they all come together and join at the edge of the recti abdominis muscles. That line at the edge is called the linea semilunaris, which means half a moon. And then you've got the recti muscles, and there's a bit in the middle, which is the linea alba, and that means white line. And that's exactly what it is. So just to go through that again, we have right in the midline a fascial layer, a thick, tight. No, it's not that thick actually. It's a strong fascial layer called the linea alba. Then we've got recti either side, the strap-like muscle. Then we have another connecting area called the linea semilunaris. And then we have three layers of muscle: external oblique, internal oblique, and transversus abdominis. And they all connect at that linea semilunaris, and then they go back and round. And they are connected to the rib cage, and they're connected to the pelvic brim at the bottom. I'm going to put a picture up in a second, which I think you're going to put up for me, Matt, which is the first picture that I asked you to show. And this shows basically what happens to the layers of muscles on the anterior abdominal wall. I'm going to just give you a second. Are you...
It's up there now on the screen. It might take.
Oh right, of course I can't see it.
Yeah.
Yes.
Just listen to the podcast. This is going to be an episode where it's worth jumping onto YouTube if you can to see the images. We'll try and describe what we're showing on the images, but the best thing for you if you can.
It's not that one. It's the next one.
It's the next one. That's okay. That's fine.
Yeah.
There we go.
Because that's all about diastasis. Hopefully it's the next one. Otherwise I've given you the wrong numbers to take a picture.
No, I've only got two.
Yes, so hopefully it's this next
4.
one you're about to show. Otherwise it's fine, because I can just describe it.
So I've got the one of the upper torso now, lateral view, showing diastasis recti abdominis wider women present. Okay, well this isn't the one, but this is a good one. So this is the outer bit of the external of the anterior abdominal wall once we've taken off the skin and the fat. So if you go to the one with the muscles on, yes. So the point that this slide is particularly making is that the anterior abdominal wall muscles are not working on their own. They are connected to the rest of the musculoskeletal system. And I probably mentioned it in the last podcast, is that we humans have divided things up very neatly into little packages. And so we've divided that anatomy up and given it all names. However, everything works as together. It's a system, a musculoskeletal system. And so we have the anterior abdominal wall is intimately connected with the upper and lower limbs. And what I'm pointing out in this particular picture is that we've got the abdominal head of pec major is actually, it inserts onto the external oblique aponeurosis. So we've got one of our upper limb muscles, or one of our chest muscles, that actually attaches to the external oblique. And we've got serratus anterior, which is that muscle that you see in, for example, boxers, that comes around and is one of the scapular stabilizers and helps with shoulder protraction and retraction, stabilizing the scapula, and that one interdigitates with external oblique, and so sort of tucks in like that. And so we have direct connections between the upper limb and the lower limb, and they are all part of what I love this term, is called the thoracopelvic manometric system. So it does exactly what it says. So we've got the thorax and we've got the pelvis. So the thorax being everything above the level of the pelvis, and that system, manometric, is to do with pressure. So all the muscles of the anterior abdominal wall are trying to create a kind of pressure effect of the abdomen, so that the lower limbs can, for example, move whilst the upper limbs are stable, and the force of the upper limbs can actually then be
transmitted through to the lower limbs. So you can imagine when you're running, you want to have a nice stable thorax so that your legs can move well underneath, and your legs are able to easily move the mass of your body forwards, whilst at the same time your arms are helping to drive your legs by transmitting force through the slings across your body, both on the front and the back. And also then we've got, for example, you think of a javelin thrower who's going to try and throw the javelin across, and they are going to be trying to transmit. So they're going to stamp their leg down, they're going to try and throw that, and that all needs to be transmitted through the thorax. And so, you know, the abdomen, the muscles there, we you know, people tend to think of like sports injuries being related to the arms and legs and, you know, pelvis, gluteal area. But in fact, obviously, we've got muscles and tendons and nerves and ligaments and fascia, all of the anterior abdominal wall, and they can get injured as well. So I'm just trying to make sure that I've thought about all of the anatomy of the front of the wall. So we've got our skin, our fat, we've got external oblique, internal oblique, transversus, we've got our recti, and then we've got transversalis fascia, which is another layer of fascia before we get to the peritoneum, which is basically the sac that holds all your organs together. So that's the anterior abdominal wall. There are a few little quirks. So the upper 2/3 of the anterior abdominal wall, in fact, I'm going to start that sentence again because just to explain it better. So the recti, their job is to kind of curl us forward, so to get us to bend over, because that's the way the striations go. So their job is to flex us. But because they're so long and they're only connected at the top and the bottom, what happens is they are held together. So if I now tip the body up, they are held together in a rectus sheath like that. And that sheath is made up of layers. The top layer is made up of the external oblique aponeurosis, and the bottom layer is made up of the transversus abdominis aponeurosis, and internal oblique gets to the edge and splits, and half of it goes up and half of it goes down. That is the situation for the top 2/3 of the abdomen. And then you have something called the arcuate line, which if you look at people who are really ripped, about 2/3 down the abdomen, there's almost like a line that goes across the abdominal wall. And then below that layer, basically everything attaches to the rectus sheath and goes up and over the top. And the only thing you have on the bottom is the transversalis fascia. So the lower 2/3 of the anterior abdominal wall are slightly weaker in terms of, for example, allowing hernias to penetrate the abdominal wall. And in particular, as we get even lower down near the inguinal canal, the external oblique is deficient. In fact, I won't get too complicated, but basically there's an area. So if this is, let's say, this is the pubis like this, about 1 centimeter up and 1 centimeter across, there is an area called Hesselbach's triangle, which is where there is only transversalis fascia and no muscles in a small area, because the spermatic cord, which is coming from inside to outside to get down into the testicles, is passing from the inside, essentially, of the abdomen to the outside. And that area is vulnerable to having hernias. So a hernia is where, in the anterior abdominal wall is where the structures or the organs within the abdomen push out with a covering of their peritoneum. So that's the sac. They push out and they can go out through a defect in the anterior abdominal wall. So in Hesselbach's triangle, they would go through the transversalis fascia straight out like that. That's a direct hernia. If they don't actually go out through a defect, the other place they can go out is through the inguinal canal, because what happens is that the tubes come down from the inside of the abdomen, go in the internal ring, down the canal, and then pop out to go down into the testicles. And so this is the internal ring is not a defect. It's supposed to be there, and the stuff can go, so it comes out and down. And like that. I'm probably getting a bit technical now, but those are the types of inguinal hernias, and I might come back to that later to explain it a bit better. But I just wanted to explain the difference between the top 2/3 of the abdomen and the bottom 2/3 of the abdomen.
I just ask a question because
Yes.
sorry to interrupt, but that's touched on something that I was interested and wanted to ask you later on with regards to hernias. But you mentioned one reason why the lower third is in comparison weaker. Is there anything else? When I look at hernias, and especially when you're talking about coughing and sneezing and things which we know we're going to have to do, why is it that humans are susceptible to these kind of protrusions and movements and what is it because that lower third needs to be, for a number of reasons, kind of weaker to allow something? Or
well, so I've said it's weaker, but actually that's a bit of a misleading statement, because actually the fascia of the lower third of the anterior abdominal wall is stronger. So the 𝐵𝐴𝐵 has different collagen type compared in that region compared to the upper abdomen. And so in fact the 𝐵𝐴𝐵 is stronger between the umbilicus and the pubic symphysis. However, the reason the lower abdomen is weaker is because we have to have these apertures for the structures to get out. Now, the reason why we have these kind of what look like ridiculous areas of weakness that can result in hernias is because the same anatomy is in quadrupeds. And in quadrupeds, so things that are on four legs, these are not like this and then come out like this. They're obviously like this. And so the pressure from gravity isn't downwards and therefore poking outwards. The pressure would be the other way. So you don't get dogs with, well, to my knowledge, you don't get dogs with inguinal hernias in the same way as you do with humans, because we are relatively newly upright and we have evolving anatomy, and that anatomy, in order to allow us to stand upright and be bipedal, and so the pelvis is upright, and we have got this tougher lower third of our anterior abdominal wall, but we still have to keep those evolutionary bits where that allow the tubes to get from the inside of the abdomen to the outside, to get the testes outside of the warm interior. They need to be in the cool exterior, and so that is an adaptation that we have. We've adapted to being upright faster than we've able to correct the problem. And of course, people have reproduced before they end up with a hernia. So, and you can survive a hernia. So there's little evolutionary pressure to correct it, if you think about it like that, really.
Yeah, that's very interesting, and that adds a couple, I think, to a list that suggests that maybe humans did evolve a little bit too quickly when it came to jumping up on the hind legs to be able to see prey, or whatever the reason was, or because there are a few little leftover weaknesses. I mean, obviously the grand scheme of things. What's too quick,
really, though, you know, and there was no design. It was just, it's one of those things, and we evolved to fill a niche, and we're also living much longer than we ever were supposed to from an evolutionary perspective. So
yeah, no, it worked.
We're very expendable from a universe point of view. But it's maybe getting a bit deep.
That's healthy to remember that now again. It's a good T-shirt. Poster. No, brilliant. That's really interesting. That's answered that my question. That's wonderful. So yes, sorry, I interrupted.
That's all right. So so I think I've talked about. So I've just got written down the layers of it. So fascia, muscles.
I have got the other diagram if you wanted to, which was showing the ultrasounds, and you want me to bring that one up.
Yeah, so there's one that's got the layers of the anterior abdominal wall, I think, and then there's got one that's got the ultrasound of the whole anterior abdominal wall.
The slide I've got is Diastasis Recti Abdominis, 𝐏𝐻𝐴, and it's got a white image with 6 different.
No. I mean, that's vaguely interesting, but not that interesting, because actually I don't think that it's very helpful.
Okay, we'll get rid of that. That's fine.
Yeah. So I mean, those are just different types of gaps that you can get, but I actually think that mostly people end up with a diastasis in the region above their umbilicus, because that's where the baby pushes out the most. But we can talk about that when we get onto that bit, I think. Definitely. The only other thing I haven't mentioned is the nerves of the anterior abdominal wall. And so the nerves that supply everything from kind of the armpit downwards are the nerves that come out of the thorax and the lumbar spine. And it's very simple, because they come out in lines like this. And so, in fact, I shouldn't be going like that. I should be going the other way because they come from the back and they go round. So we have an anterior ramus that goes from the back and comes round and supplies the skin like that. We've got one small one, and I'm doing it the wrong way around. So it comes out of the spine and then goes through the back muscles, the paraspinals, and supplies just a little bit of skin over your paraspinal muscles, which is why sometimes people can get like a feeling like they've got a little tingly numb patch if they've got a muscle spasm, because the little nerve that's the segmental nerve that's coming out of their spine is probably being annoyed as it passes through to the skin. So that would be the posterior ramus of the that segmental nerve. So let's say it's the T3 level, which is probably somewhere up here. We've got T10 around the umbilicus region, and the last level is L1 that supplies down towards the groin and just above the pubis, and then we move into L2, which is sort of groin, and L3 and 4 down the legs. So that's the dermatomes, the bit of skin that is supplied by those segmental nerves that are coming around the spine. And like I say, they come round in hoops. And you get a little branch that comes out the side. So that's the lateral anterior cutaneous nerve. And then you get a little one that comes out the front, and that's the anterior cutaneous nerve. And they can be entrapped, giving you something called acnes and lacnis, or I don't know how you say the acronym, but it's basically ACNES or LACNES, and that's just entrapment of that little nerve as it passes out through the different muscle layers. And you can actually get something called Pockness, which is what I talked about before, is going out through the back. So those little nerves, as they're coming out, and so you can get problems along the side of your abdomen, or problems along the front, and they can give you pain and paresthesia, so altered sensation and things like that. The nerves are followed by vessels. I'm not going to talk about vascular injury, except to say that you can have injuries of the vessels at the rectus muscles, in the area where there's no posterior sheath, because that sheath is protective, and where there's no posterior sheath, the arteries and veins that travel there are more prone to injury, and so you can get rectus sheath vessel bleeding, and that can give you a rectus sheath hematoma, and that is extremely painful. And can present itself like a surgical emergency because it's so painful. It causes redness, swelling in the rectus muscle of the anterior abdominal wall. The only other thing I was going to say was, obviously we've got our skin, and so I'm just thinking in terms of what people who do soft tissue therapists are going to come across is someone might present to you with something going on with their anterior abdominal wall, and of course it might not be in the muscle layers. It could be deeper in the organ systems, but that will probably present in a slightly different way. But then it could of course be on the skin. So we've got rashes, so you can have viral rashes like shingles. They would present as a band around in one of those segmental nerves, and they wouldn't cross the midline because it would only affect one nerve and it would stop at the midline. So that would be a vesicular rash in that particular band. You could have skin infections. You can get lumps in the skin like lipomas. I'm sure you've all come across just fatty lumps in the skin. And finally, the edge of the rib cage. People will, talk about getting pain around their ribs, or they will have and that's where our muscles attach. And actually external and external oblique will go slightly up above the rib cage, and internal oblique is essentially the muscles, the intercostal muscles. That is essentially internal oblique between the ribs, and then you've got transversus below. So I think that's basically all of the anatomy. I know it's a bit of a rush through. If there are any questions about the anatomy, I'm happy to take them now. Otherwise, I'll start maybe talking about problems of the anterior abdominal wall.
That's great. No, that's a wonderful breakdown, and it's wonderful. And that's what they said last time, because people obviously on the podcast, they can pause it, they can preempt with an answer if they're leading towards something they know. So it's a lovely way to revise it. But if anybody does have questions, I think they've all just got pen and paper out and they're just sitting down, scribbling down frantically, like students that they are. So
the lovely thing about the anterior abdominal wall is that because it's just below the skin, it's absolutely fantastic to see on ultrasound. So it's one of the easiest things to scan because it's just there, So you can see all the different muscle layers, and I might see if I can actually bring up a picture and just show it to you, but I'll do that in just a second. So in terms of what can go wrong, all the structures I've talked to you about, something can go wrong with those different layers. So I've nearly got it up, and I'll get that up in a second. And so I'm going to talk to you about what can go wrong in the fascia. I'm going to talk to you about what can go wrong with the muscles. And I'll talk to you a bit about hernias. And I think I'll probably stick with that because I think that'll probably take us all the time. So I'm just going to see if I can show. And now I know it's not ideal. Ideally, we'd be able to share the screen, but unfortunately, my laptop is too old, and Matt hasn't offered to buy me a new one.
Not yet. I said 2 more shows, and then we'll talk about it.
Yeah. So this is an ultrasound picture of the anterior abdominal wall, and I know it's not perfect, but
Oh,
this.
you can see that. That's good.
Yeah, I know I'm getting.
Flexion now.
Yeah. So it shows you the recti muscles, and they've obviously highlighted, and at the side you can just see the 3 layers just poking off on either side. This is actually my anterior abdominal wall, so don't have to worry about anybody showing their abdomen. So you can see how beautiful that you can actually see the muscles there. So that's basically looking in from the front, looking towards the back, but I'm only looking a few centimeters deep, and so you can beautifully see the 3 layers. Okay, and the other thing is with ultrasound is you can see it dynamically. So you can see what's happening when people contract. So you can see with the rectus, particularly when people have a diastasis, you can see what's happening when they contract their muscles, whether they're able to bring it together, etc. So I'm going to talk about that now. So I call it Diastasis Recti Abdominis, but lots of people call it different things. But we're going to call it diastasis tonight. So DRA, it is a widening of the linea alba, so the fascia in the midline of the abdomen, caused by anything that takes up extra space inside the abdomen. That could be adipose tissue, that could be some kind of cyst that is swollen, but most commonly it is due to pregnancy, because we have a growing mass inside the abdomen, a lovely mass which turns into a lovely baby. However, it's taking up space, and so we need to make space for that, and the way that the body does that is by stretching. And so the linea alba at the front, so if these are the 2 recti, the recti just get wider apart, and the fascia just stretches. The fascia doesn't stay the same thickness, it thins when that happens. And then once the baby is born, then that fascia can come back together again. It usually doesn't come back completely. I think most ladies who've had a baby will find that they have a wider waist measurement afterwards, because they've had something that's inside that has stretched everything. And in some women, it comes back together far better than others. So those people who are more at risk of having a diastasis are people who have bigger babies, and usually that's people who have a baby that's more than about 4 kilograms. So that's 8.8 pounds, 8 pounds, 8 ounces. Then it's somebody who might have more than 1 baby inside, so twins, triplets. Somebody who has a baby and something else inside, so that something else could be water around the baby. There could be too much. It could be a womb with fibroids. It could be anything that takes up extra space. It could be adipose tissue. So it could be that if someone has a high BMI, they also have extra fat within and around their organs, which is already taking up some space, and then you add in another baby. And the other people are people who have increased mobility of their fascia, so people with connective tissue disorders, who are more stretchy anyway, are more liable to stretch. And finally, people who are more at risk of diastasis are people who have babies when they are older. So those people who, and in my experience, generally around the age of 38, 39, 40, if you have a baby around that age, you are less likely to find that your linea alba comes back together as well, because our tissues are just less elastic after that time. And so certainly having babies after the age of 40 will have a greater impact on the musculoskeletal system because it's just not as stretchy and elastic. And so all those people might be more likely and so when I'm speaking to ladies with a diastasis, I'll be asking all these questions. And the thing about a diastasis is that it's really common, and most women will find that it will come back together with the right advice. And one of the main things is that you need to restore the strength control of the layers of the anterior abdominal wall. Actually measuring a diastasis, in my opinion, is best done using ultrasound, because it's not about the gap between the recti muscles, it's about the length of the linea alba. When you're lying down, so if you're lying down, your abdominal contents will sink into your pelvis, up under your diaphragm. So there's no pressure on the anterior abdominal wall when you're lying down. So if you have a linea alba, let's say, that's 4 centimeters wide, it may be that when you're lying down, it just kind of collapses a little bit. And so the recti seem to come together, and you either have a corrugated linea alba between the two, or it just dips down like that. If you then increase the tension of the abdomen, what can happen is that you can have really good recti apposition, so they can come together. And so you think, well, I haven't got a diastasis because actually my recti are together. But that doesn't mean that you don't have a diastasis, because the linea alba could be corrugated in between. Now, if you've been really effective and you've managed to get it together before anything else is able to come out the bottom, that's fantastic. But some ladies find that when they contract their abdominal wall, rather than being able to get their recti together, the loose linea alba in the middle bulges up like that, and their bowel sneaks up into that space which has been left by the linea alba. Now, I know that physios like to work on helping women to contract their abdominal muscles in a certain way so that they don't get that kind of bulge. But regardless, the linea alba still has available space. And generally, we tolerate a linea alba length, in my opinion, of about 3.5 centimeters or less, certainly less than 3, reasonably well. My opinion is also that when we get to about 4 centimeters or more, I think ladies tolerate it less well and they aren't able to compensate. And the reason for that is, in particular, is we've just talked about what happens when you're lying down. But when you stand up, your guts fall down from underneath the diaphragm and they fall down into the pelvis and they put pressure on the anterior abdominal wall. So now that linea alba is not going to be corrugated between the two. It's now going to fill, and it's now going to push the recti apart because it's now going to be under tension. And so now, number one, that's quite hard to feel and palpate. So as an examiner, I find it very difficult to examine women. In lying, it's easy, but it doesn't matter because it doesn't count. It's a false reading, in my opinion, in lying. In standing, it's very hard to feel. That is the correct reading. And because it's hard to feel, the best way is, in my opinion, ultrasound. Because if you ask them to contract, again, it can come together, but it's not the gap, it's what happens in the middle. So if you come together, you might be able to get it in, but there's still either going to be a bulge, or it's going to dip in, or it's going to corrugate. Now, I had a lady who was a physical training instructor, and she had a 13 centimeter diastasis. And so in a kind of diamond shape, just above her umbilicus, over about that kind of segment, and 13 centimeters wide. And she in lying, she was brilliant. And in fact, in standing as well, she was able to get her she was able to get her recti together. But just occasionally, she wouldn't quite manage to do it quick enough, and her bowel would sneak into the linea alba and she would pinch it, and that would cause her pain. And when she was weightlifting, because she wanted to still keep very fit, and she was able to, she's a physical training instructor, so she would actually use one hand to hold everything in and the other hand to hold her weights. And then she would do everything by providing manual pressure over the gap in the linea alba. So in summary, my feeling is that we should be examining people in standing so that we understand what the width of the actual linea alba is, and that the best way to do that is with ultrasound. Now, once you have a linear alba that's wider than probably about 4.5, 5 centimeters, if you think about what's happening to the external oblique, internal oblique, and transversus, is that they're trying to, so their job is to pull on the rectus sheath so that the rectus can then flex you forward. And if you have a very wide linear alba and you want to try to make it rigid so that the recti are then under tension, if you contract, there's only so far a muscle can contract. You can't keep contracting. It's only got so much pull in it. And so it can pull to here. And the question is, with that one pulling that way, that one pulling that way, and that one pulling that way, is that enough to get rid of the corrugations in the linear alba? If it is, you'll be able to tension the linear alba, you'll be able to create intra-abdominal pressure, and you'll be able to move effectively. But if that gap is too wide and you haven't been able to tension it, you're going to struggle to make like an intra-abdominal pressure. And so either you just don't, and you might, for example, get problems with back pain, or you might get a bulging effect of your bowel coming forward to fill up that space as you try to make the abdominal pressure. Or you do something else, which is sometimes women will pull on their pelvic floor to start squishing up from the bottom. And then they find that they're getting maybe pelvic discomfort or pelvic floor pain because their pelvic floor is constantly switched on to try to create some pressure in the intra-abdominal space. And that can cause issues with, if you have a hypertonic pelvic floor, which means it's turned on all the time, that's, reasonably effective until you stumble or sneeze, and because there's nowhere for the pelvic floor to go now, it's already turned on, then you can leak because the pelvic floor is already on, there's no further lift available, which is what it's supposed to do. What the pelvic floor is supposed to do is it's supposed to be able to lift when there's a problem and relax when there's not a great deal of tension. So if you're running along, you're going to have slight tone in it, and then if you were to stumble, it would lift in anticipation that intra-abdominal pressure is going to go up. So that's what I mean. If it's on all the time, there's nowhere to go. So people can get sort of stress incontinence, even though their pelvic floor is super strong, because it's trying to create extra intra-abdominal pressure. And the other thing that can happen is that women, so they're pulled on the pelvic floor, they're squeezing from the side, they will also push from the top. They will use their diaphragm to create that kind of cylinder effect so that they get intra-abdominal pressure. And then ladies will say to me, well, I'll say, can you run? And do you get breathless when you run? And they'll say, well, I feel like I'm shallow breathing. Because if you think about it, if you push down with your diaphragm to create intra-abdominal pressure, suddenly you can't catch a breath because that diaphragm is doing work in the abdomen. It's not there to assist with breathing. And so often, as I say, they'll talk about struggling with breathlessness while they're running, or just an inability to take a full breath. So those are the kind of problems that I see in the ladies that I look after with diastasis. So they don't come straight to me. The way it works in the MOD is that they see a women's health physiotherapist who will work with them, try and make sure that they are strong, make sure that they do all the good work, make sure they've got good pelvic floor, potentially check that the pelvic floor is working as it should. And they will go through a period of rehabilitation. And then if there's concern that it's a wide diastasis, or that they are having other issues similar to what I've just spoken about, they will refer them to me, where I will do an ultrasound scan. And I will scan them in lying, but also I will scan them in standing. And that's the critical one, to understand exactly what's happening to the linear alba, when it's under abdominal tension, essentially. And I will look and see what their external oblique and external, internal, and transversus are doing. I will look and see what's happening at the linea semilunaris. There was one lady who did actually have some stretching there as well, because of course you don't have to just stretch at the linea alba, you can also stretch at the linea semilunaris. So then you end up with some widening both either side of the recti and also in the midline. So these things are not as, it's logical, you can understand why it happens, but it's not as simple as you think. But when it comes down to it, it does end up feeling like it's kind of just common sense. And and you can listen to the experience that that women have when they're moving, and you can understand why they're struggling, because they aren't able to create tension in their torso, which I think means that they are probably less likely to be able to transmit from forces through their upper limbs. So they may feel like they're weaker in their upper limbs. They can't breathe so well when they're running. They feel like they don't have abdominal control. They might be getting some back pain, could be getting some pelvic pain, stress incontinence symptoms, and they might feel that they feel wobbly when they're kind of running because they are not able to control what's happening around their middle.
So a question, I'm just thinking,
yes.
So it's quite a masquerader then, so that it could go undiagnosed, particularly with we know there's for various reasons, a lack of education when it comes to women's health, even amongst the women themselves, that they put up with a certain amount of leaking, so they just think, oh, I've reached that stage in life or something. So when people do come to us and we ask these right questions, particularly soft tissue therapists, where someone's come for an hour and they've got more time to actually fill out a PARQ properly and have that conversation, this is something which we should be investigating and looking out for, so we do refer them on, because like you've just said, it could be an upper body weakness, it could be out of breath and they're thinking it's a performance issue, my training needs scheduling, when in reality they're living maybe with postpartum diastasis and they haven't considered that could be connected.
Yeah, you're absolutely right. Yeah, so you raised two really important points. So number one is that women believe that, and obviously I can speak for myself, but I think we assume that these things are, yes, of course they are part of having a child and they're part of being female, but that doesn't mean that, and of course it's natural, but it's natural to be susceptible to disease. It's natural to, but that doesn't make it a fun thing to happen, and doesn't mean that we should just leave it. And so absolutely, this is something that is part of a normal pregnancy and having babies, but actually can leave you with a problem. And so that's the first thing, is to recognize that natural things can cause problems. And the second thing is that we should all, as clinicians, be asking women, if have you had any children? Do you think that you have any weakness of the anterior abdominal wall? Do you think that you have a gap? Do you think you have a mummy's tummy? Asking them whether they feel like, and they might say, oh yes, but isn't that normal? And it's like, well, it is normal to have that if you've had stretching of the anterior abdominal wall, but that doesn't mean that it's not a problem. So yes, so those two things, making sure that we ask, and making sure that education piece about not necessarily putting up with what life has given to you. Yeah. And I would say in particular people with back pain. So ladies with back pain, we should always ask anyone who's had a baby with back pain about their pregnancy history, about big babies, about connective tissue disorders, or even just, you don't even have to ask them, have a look at their anterior abdominal wall as well. Just because they got pain on the back doesn't mean we shouldn't look at the front.
That's what putting it. Yeah, it's interesting the number of times when we've looked at women's health, and even when we did an episode on the core and kind of like modern interpretations of what the core is. I think it might have been Owen Lewis, I think it was, but somebody mentioned a couple of times that we automatically think that we need to tighten stuff up. It's because things are untrained and muscles are weak, when really a lot of the time it's actually the bracing which is causing the issue, and it's actually letting go of these things. And you've just summed that up wonderfully with the idea of trying to create that pressure by pulling up from the bottom and pushing down on the top. So letting go, it's amazing stuff.
The difficulty is so I don't want you to leave thinking that we have to get people to relax. And
no, because they're bracing for a reason.
And actually I think that once you get over about 4.5 centimeter gap, particularly in the military, where they're going to be asked to put heavy weights on their backs, they're going to be asked to run, they're going to be so occupational fitness. But that probably goes for police officers. It probably goes for firemen or fire people. We should be aware that this could have an impact on that. And actually, for the ladies in the Army, Navy, Air Force who have this problem, we are now referring, or I am now referring them for a surgical repair, because they are not going to be able to overcome that mechanical disadvantage through strength work, in my opinion. And so we've had about 12 ladies now go through the surgical procedure. which is basically done by a plastic surgeon. They do an incision from the iliac crest to iliac crest across the front, similar location to where they might have a cesarean scar, but much wider. The anterior abdominal wall is lifted. They sew up the linea alba, and they bring, it's slightly more complicated that in terms of bringing the umbilicus up to the front. Then they sew everything down, and after 6 weeks, what the plastic surgeon says to me is that they are bulletproof. Now, we take it slightly slower, so we say at 6 weeks they're ready for doing good, functional strength and conditioning, and at 12 weeks we allow them to do any kind of abdominal loading they like. But between 6 and 12 weeks, we're just a bit cautious. The results are absolutely incredible. So I've had a lady, I've just had a variety of different ladies who've all gone back to full physical fitness. So the physical training instructor, she had the surgery. She's, they go off into the distance because they're back fully deployable, fully fit. The anatomy is essentially fixed. So this is life-changing surgery, because these are people. So if you think about like an ACL, and you have an ACL reconstruction, that is not an anatomical fix. That is trying to recreate something that is, beautiful evolutionary design. So we have done a reconstruction. We've attempted to do something, but that knee is now subject to potentially having arthritis in the future. Whereas repairing the linea alba, sewing up that gap, or narrowing the recti, is restoring the anatomy that you had at the beginning. It repairs the anterior abdominal wall, and that is now fixed. And the ladies talk about feeling like they have their bodies back, feeling like they are able to move well, like their upper body on their lower body. I had one lady who'd had 3 years of sciatic pain, and she woke up after her surgery, bearing in mind she had local anesthetic still in place, and she said that she felt like her sciatic pain had almost gone. She's had during rehab, she's had just a few little blips, but essentially she is now, the rehab is now working, whereas before she felt that they all feel they were doing the work, but they weren't able to engage everything properly. So I'm a big advocate for surgery to restore anatomy in women who are proven to have a diastasis that is affecting their function and causing them symptoms. So at the moment in the NHS, this surgery is considered aesthetic. Now, there's two things about that. Number one, for some people, if you have less than about 3 centimeters, maybe it is for an aesthetic purpose. But for some ladies, this is not aesthetic at all. This is about function, and this is a sexist or sexism within our healthcare setup, in my personal opinion, where just because historically this is something that we have thought is a natural part of women's life, and perhaps what happens is women just accept a lower functional level. I think that many women these days aren't willing to accept that because of changes in the way society is working. And we should be supporting people to stay fit and stay active and not have back pain. And therefore, to me, it seems ridiculous that we wouldn't repair something that could restore someone to their function, rather than say, well, actually, instead of repairing this, we're just gonna ask you to do less. Because women with a wide diastasis usually cannot do high levels of activity, because it usually brings on some kind of symptom. And so therefore that would potentially lead to problems with raised BMI, diabetes, cardiovascular disease, which then could in itself lead to arthritis, chronic disease. So this has a huge implication, and I think would be a massive cost saving. The way to set up the pathway, though, is to set up a pathway where we look at women's functional ability to move, and we look at using ultrasound to actually accurately measure the diastasis, work with our women's health physio colleagues to provide strength and control work, and then in those where that doesn't work alone, do surgery to restore the anatomy of the anterior abdominal wall and restore function. Now, I may be too old before that all gets sorted out. However, at the moment, the women in the military are benefiting because of what the military asked them to do. And I'm really proud of that, something that we've set up.
It's great stuff.
I've gone off on one of my rants.
No, it's an amazing message, and you've given me a perfect kind of minute cut now to advertise and put things out there. It's a really important message, really cool. Yeah, I was waiting for you to say that the NHS regards it as aesthetic. It's just, oh, do you really need this? Is it that important? And it's yes, it is typically, yes, sexist, let's face it. Although it has coincided nicely with a question regarding, because men can get, I mean, it's less likely, but I think I've come across bodybuilders in particular with extreme kind of internal pressure and lifting, that sort of stuff. And actually it's coincided with the question from Nikki, which is related to the army as well. Nikki Mansfield says, I brought the question up on the screen, I guess the ratio of male to female patients with DRA is low. What have you found to be the main reasons for the men present with DRA? Are there any related to intense physical training, e.g. army training? Because men can get, I think I know someone who had the surgery as well, the abdominoplasty, whatever it's called, because, and it was for aesthetic reasons for this guy, although I think it's been linked with potential erectile dysfunction and stuff for the same kind of reasons, but he just had it done because he was sick of having this look. He was a bodybuilder and very vain with it, obviously, and he had the surgery done. But yeah, what are causes for men? Do you see it in the army, the similar
so I don't see it in physically fit guys with a normal BMI who are doing normal military training. I do see it in people who are powerlifters. That is a bit of niche. So most people in the military aren't necessarily in that. They're not doing the same thing you would see people benching and things like that. And it is often those benching type maneuvers, really, you know, that you can imagine that sort of back arching, massive intra-abdominal pressure kind of. Also, you know, squatting. So they can get this defect in the anterior abdominal wall in the way. My do have more than just. So they also have intra-abdominal fat. So men tend to carry their fat inside their abdomen rather than in the subcutaneous tissue. So if you have, and people who are powerlifters often can tend to be more muscular, but also just bigger generally. And some of that can sometimes be intra-abdominal fat. So you've got the increased abdominal pressure, and then you've got increased adiposity around their organs, which is taking up more space. And then you've got, and then this pressure that's higher than the capability of the fascia to manage load. And then you can get diastasis in men as well, with what is more typically called a ventral hernia, which is essentially what a diastasis is. So it's not a true hernia in that the intra-abdominal contents haven't exited through the anterior abdominal wall. They've just caused the anterior abdominal wall to bulge. And so, so what I do see in is that male women who have a diastasis are more susceptible to, because their linea alba is thinner, is having epigastric hernias or rather midline hernias. So that's hernias in the linea alba, so small defects in the linea alba where a little hernia has just poked through, basically. So you get them in, I'll just say, get them in the epigastric area here, or paraumbilical, often just fat filled, so they aren't a bulge of the peritoneum, so that's the abdominal cavity, often hasn't gone through. Often it's between the sac and the transversalis fascia. There is a little area of pre-abdominal fat, and that can poke up and go through little defects in the epigastric linea alba, or around the umbilicus, or at the umbilicus. When you have the diastasis repair, they just get sewed in, they just get dealt with. Sometimes, so if you want to have your hernia repaired on the NHS, that can be dealt with, but most often, so there's a difference. So a diastasis repair is not the same as an epigastric repair. So that would be a localized repair. It's usually done by an incision straight overlying the area where you have your hernia. So you end up with a little scar just where that little hernia is. Whereas a diastasis repair is most commonly done by a plastic surgeon through a lovely incision that ends up fading almost to nothing. Now, I've referred people with a diastasis and a hernia on the NHS, and one guy had an epigastric hernia that was relatively small that caused him pain on doing sit-ups, and the surgeon said, yep, no problem, we can fix that for you, and he's on a waiting list to get that done. Meantime, I've sent someone with a large para-umbilical hernia to the same surgical team. She has had 4 children. She has an associated diastasis, and he said to her, have you had children? This is normal. You don't need surgery.
Oh no, this is terrible. I can see why you're fuming
and
about
it's
it.
and it just makes you feel sort of sick. And what I actually then just applied for her to have it done through the military pathway. And when the patient has waited that time to see that surgeon, and then you think, well, I could complain, but actually I don't want them to do the surgery regardless, because they're clearly not my favorite person on that particular day, and so therefore I'm going to refer them to somebody else. And I think that it's terrible misogyny within some areas of the NHS, and maybe that's an education piece as well, but that is just because that lady still needed to be fit. She's had the same requirement to pass the same fitness tests, but was considered to be in a different category. Is what it is.
Okay, but like you say, the military, where they actually need the ladies, and say, oh, you're injured, are you? Yes, we need you. Then maybe that's, with you spearheading it, that's where the change will come from. Look, it's 9 o'clock already. It's been amazing. Obviously, we could go on for longer. But Becky Carroll has summed it up. There is no other emoji to use their furious red faces across the screen. Vicky Mansfield as well. Absolutely shocking, furious faces. Amazing to raise that awareness. Very interesting. Right, okay, it's time though. So we're going to have to knock ahead. I'm sure you've got other things to do, and people joining us at the live lounge. We try not to overrun. So thank you so much, Sarah, for joining us. Dr. Sarah Rollins.
Pleasure.
If people want to follow you on Twitter, is that probably the best place?
Yeah.
Dr. Sarah Rollins.
Yeah, that's me. Yeah. Occasionally put stuff on about diastasis and some pictures.
That's great. And then you're based, you consult from Pure Sports Medicine, Rains Park, and they've got a website there. Obviously, people can.
Yeah. So if there are ladies, if there are ladies who want to actually see someone, so that I see lots of women, in that private clinic who have diastasis, and I refer them on. Obviously, it's difficult for it's a paid service, but if there are people who have private healthcare, you can. Because of it being essentially under the category of, especially if they've got back pain, then it's usually covered. The only thing that isn't covered is then the surgical referral at the moment.
Okay, well, we'll put all of the contacts and everything in the show notes. And if you, just the best way of raising awareness and making a change is just by educating people. So share this episode. I will make a little snippet of this which talks about this in particular, so share that on your social media so other people get to know it. And there's misogyny, but often, like you said, Sarah, it's because of poor education as well. And people are often scared of something that they don't know about and understand about, especially if they're very high in their professional field. But education
perhaps misogyny is the wrong word. I think it's sexism is the right word, because it could theoretically also have been done by a woman, just because of the way that people have been trained and the way that it's more that woman was treated differently rather than it being a man that treated her badly, if that makes sense. It was so more
blatantly so strange that we're drawing in our breath like, well, that's out of order, and yet it's a protocol. It's like, and it will happen again with somebody else in the same situation. It's very strange. Anyway, fortunately on this show we get to meet people like yourselves and lots of other people working in the field who together can make a change, I'm sure. So thank you for that. Thank you for your endeavors. And we are going to be, like I say, this is the first part, wonderful introduction. I love the way you've introduced the anatomy, because it's just going to help with the next episodes coming up. If you listen to the podcast, it is worth looking at YouTube and watching it, because all the muscle directions, and often the function of the muscle is obviously to do with the direction it's going with the obliques and everything. And there's lots of hand gestures and movements, and you need to watch Sarah Rollins in action to truly understand what she was talking about with regards to the musculature of the anterior abdomen. So do watch YouTube if this has appealed to you and you're interested in listening to it again. Next week, My guest will be Dr. Dora Papadopoulou. Is that good pronunciation, Penny? Impressed with that? Talking about sports-related groin and abdominal issues. So we will be talking about similar things. There's obviously going to be an overlap, but with the great introduction we've had tonight with the anatomy, then that's going to be really useful to take in the next 3 sessions on this topic of the groin and abdomen. So thank you, Sarah Rollins, for setting a fantastic foundation for the rest of our guests. I really appreciate it.
My pleasure.
We got down here, we've got a few more comments coming in just to finish off the show. Nikki Mansfield has said, wow, Sarah, for a niche subject. What a massive subject. Thank you so much for sharing your immense knowledge. Thanks, Nikki, for the feedback. It's lovely. Tracy Taylor, thank you, man. Sarah, so much amazing info. I'm going to have to listen back again. Yeah, definitely. This is definitely one of the ones you're going to have to listen back to again. I agree. And 𝐲𝐳𝐳 says, amazing knowledge. Thank you. I've taken so much this evening. Thank you, Sarah and Matt. You don't have to put Matt at the end. I just produce it. It's Sarah, Dr. Sarah Rollins, who has allowed this to happen tonight. So thank you very much. Thanks for joining us live. Thanks for listening to the podcast. And thanks once again to Dr. Sarah Rollins. Oh, by the way, Dr. Sarah Rollins, don't go away. I'm just going to shut the live lounge now.